Hello to all my dear students. So welcome to your favorite channel, You and I with Dr. Ruchi Rai. We'll be continuing with the FMG rapid fire revision. Okay. So coming to the slide number 1, what do you see here? What is this instrument? Please don't get confused. This is your aesthesiometer. क्या होता है aesthesiometer? To see the corneal sensation. So यहाँ पे कुछ questions related to cornea. सबसे पहले हो गया investigations related to cornea, right? So इसमें सब आगे ये है आपका aesthesiometer, right? How to take the sensation? Most commonly कैसे करते हो? With the cotton wisp, but you can do it with this instrument as well. Second, what is this? This is pachymeter. What is pachymeter used for? Exam question. Pachymeter आप बोलोगे for thickness of the cornea, isn't it? Thickness of cornea. ये क्या है? ये हो गया आपका. This is also exam question. Specular microscopy. So specular microscopy किसके लिए use होता है? To see the endothelial cell. सबको पता है endothelial cell is absolutely very important for keeping the cornea in a dehydrated state. So endothelial cells are examined by, we see the number as well as we also see the morphology. How many of the cells have undergone polymagatism or pleomorphism? Okay. बहुत डिटेल में न जाके, what is the normal number of the endothelial cells for adults? You should learn as 2000 to 2500 cells per millimeter. It is not cube, it is square. So keep this in mind. This is the normal number of endothelial cells. And if it goes less than 500, then the cornea cannot be in a dehydrated state, and there what occurs is corneal edema. Okay, hydration होने लगता है. So less than 500 cells per millimeter square is important. Cut off, you have to remember. Another question that we have to keep in mind is, in a corneal graph, what should be the minimum number of endothelial cells? It ranges from 1500 to 2000 cells per millimeter square ideally should be there in a corneal graft. Okay, so these are important points on this slide, right? Got it? Okay. What is the next slide showing you? This is what? This is your corneal topography. So corneal topography say what you do? We all know corneal topography for corneal curvature, right? To scan the whole surface of the cornea, क्या करता है? It measures the corneal curvature. Which other instrument can measure the corneal curvature? We will remember keratometer, right? So another instrument is keratometer. Okay, come to this one. What are the questions? What is this? Can you see this? These are the hyphae, isn't it? So ये आपके जो extended हो, ये of course keratitis with hyphae. So and dry rough look here. So we are talking about keratomycosis, that is fungal corneal ulcer. ठीक है? So keratomycosis. So keratomycosis or fungal corneal ulcer. First question क्यों होगा? Trauma by vegetative matter or organic matter. ठीक है? Remember this. Second important question is that signs are more than symptoms compared to a bacterial keratitis, right? And third is most common fungus, you will answer Aspergillus fumigatus. After this, after this, what is the option? Next best option after this is Fusarium. ठीक है? So these are some important questions. फिर आपसे ये भी पूछा है what is the drug of choice? Drug of choice is 5% netamycin. ये नहीं भूलना है. ठीक है? For fungal keratitis. And of course, another question, अगर hypopion होता है, if there is a hypopion out there, this hypopion is actually unsterile. Okay? In contrast to bacterial. Come here, this is bacterial. Bacterial keratitis, if you look here, this is one exam question, sterile hypopion. Okay? Secondly, hypopion corneal ulcer. This term is used for pneumococcal infection. Term name in inverted commas, okay? Or we also call it ulcus serpens. All these terms are used for mainly pneumococcal infection, right? So this is another question that you have to know. The third thing, most common, you will answer is Staph aureus. Most common cause Staph aureus. In India, it is Staph epidermidis, right? So just revise all these topics. I am here to only pick up some important points. You have to revise all this. And then this is your superficial punctate keratitis, which you can get either in herpes zoster or simplex. So when you talk about zoster or simplex, what we have to see here is, so superficial punctate keratitis can be, as I said, feature of both zoster and simplex. But what about this one? Can you see? We have to keep this in mind that whenever there are, what do you see here? Knobbed ends. So if there is a knobbed end, this is an actual dendritic ulcer. And look here, this has no knobbed end, so this is a pseudodendrite, right? So we all know this, that dendritic ulcer is a feature of simplex, right? Herpes simplex. If we by mistake give steroids in this condition or it aggravates, it can lead to geographical ulcer, right? And can also cause corneal perforation. Therefore, steroids are contraindicated in dendritic ulcers in herpes simplex keratitis. This has to be kept in mind, right? So, and this is what, these are the pseudodendrites. Pseudodendrites are mainly feature of zoster, herpes zoster ophthalmicus. ये याद रखना है, ठीक है? So these are the important viral keratitis का एक और सवाल है, what is the pathognomic feature of viral keratitis? आप क्या बोलोगे? Viral keratitis pathognomic feature is decreased corneal sensation. Don't forget, decreased corneal sensation. Okay, so this is one important point. Second important point is about dendritic ulcer, which can lead to geographical ulcer. And how do you treat it? Of course, acyclovir eye ointment 5 times a day, and if it is zoster, we have to also give oral acyclovir. Correct? Okay. What is this type of keratitis? We come to the next keratitis. This is a ring ulcer of acanthamoeba keratitis. है ना? Acanthamoeba, what are the points to remember? Acanthamoeba keratitis occurs due to, we all know it is not common. First of all, very important, it's a rare infection. Pehla sawal, why does it happen? Contact lens users washing their lenses. Which lenses? Soft lenses. Washing their lenses with tap water. Just remember this, right? And if you are asked what is the most common infection after contact lens use, most common infection after contact lens use, what is the answer? Ab aap bologe Pseudomonas. Now it is Pseudomonas, right? Another question from acanthamoeba keratitis is that what is the culture media? We will learn non-nutrient agar with E. coli. Okay. Next question is with E. coli. And lastly, what is the drug of choice? We will answer, I'm writing here, Fmge. What is Fmge? Stands for, I hope you know, polyhexamethylene biconnite. Come to the next slide. Next slide, this is showing you the salmon patch, which is a feature of syphilis. We are talking about interstitial keratitis. Okay. So interstitial ka matlab only, interstitial means that only your stromal keratitis and epithelium and endothelium are not involved. That is what is interstitial keratitis. Okay, we come to the, so these are the different types of keratitis, and of course, what is Cogan syndrome? Yaad hai na? Interstitial keratitis with deafness is Cogan syndrome. These are important. Just revise interstitial keratitis. What are the other causes, right? Syphilis ho gaya, leprosy, tuberculosis, sarcoidosis, and Cogan syndrome, right? So just remember, these are the important ones. Okay. So these were the different keratitis. You have to learn it nicely and revise it properly. What are you looking at here? What is this? So this is your, you all know, scleritis. This scleritis which is causing staphyloma, which is ectatic condition of the sclera. What is the scleritis? It is anterior scleritis which is necrotizing and without inflammation, right? These are the important points about this. क्या बुलाते हो इसको? We all know we are talking about scleromalacia perforans. Okay. What is the exam question? Exam question is, it is associated with, you will answer, rheumatoid arthritis. Associated with rheumatoid arthritis, right? And it is leading to which staphyloma? This is leading to ciliary area mein hai, so ciliary staphyloma. Okay, one more question, which is the most common type of staphyloma? Most common is posterior staphyloma. Staphyloma is ectasia of the eyeball with herniation of uveal tissue. Posterior staphyloma kya padha tha? Where, in which condition? Pathological myopia. Please note down, pathological myopia, right? Okay. Then before I move further, one more slide here which we miss is a recent exam question. What do you see here is a superficial foreign body on the cornea. We first in this exam assess what is the depth of the foreign body, kahan tak hai, and how do you manage it. We will just 26 gauge needle leke, you are going to remove it and then you pad and bandage with antibiotic ointment. Okay, pad and bandage with antibiotic ointment. Okay, we next talk about, okay, we come to the next slide. This is again, I think, already discussed. What is this golden brown ring? We are talking about Kesa Fleischer ring. Is it reversible or irreversible? What is it? It is copper deposition. Where is the copper deposited? Descemet's membrane. These are all cues, okay? Third question is, it is reversible, please remember, because even if it's fading, it is the sign of reversibility. Okay? So you will say it is reversible. This is about KF ring. And then what is Fleischer's ring? Exactly the same spelling, but Fleischer's is actually, can you see this? Fleischer's ring here, this whole thing, right? So this is, we all know, we have learnt it. What is Fleischer's? It is iron deposition. Where is iron deposited? Epithelial layer. Where do you see it? In keratoconus, at the base of the cone. Okay, these are the points we have to remember. Come to the next slide. Next slide is showing you further. This is the keratoconus. You all know it's an ectatic condition of the cornea. And what is the main problem in keratoconus? There is myopia to hai hi, but along with that, because the cornea is irregular, the conical protrusion is only at one side or at any one particular place, not the whole cornea. Therefore, you get irregular astigmatism. Okay, so what we are getting is irregular astigmatism. It's very important, you should know this. Revise astigmatism as well. Secondly, you all know when this patient looks down, there is a V-shaped deformity of lower lid. ये हो गया आपका Munson sign. This is also your exam question. Fleischer's ring, Munson sign. We learned about oil droplet reflex. That was also a feature of keratoconus. What another reflex that they can ask you on retinoscopy? You can get scissors reflex. Please note down. Scissors reflex is also finding of keratoconus. Then what you get here is, can you see this? These are prominent corneal nerves, and this is why this is happening. It is due to thinning of the cornea. So this is your prominency of the corneal nerves. Again is a feature of keratoconus due to thinning of the cornea. This is also your exam question, right? If they ask you what is the choice of treatment of keratoconus, of course you should answer C3R, though it is most effective when the keratoconus is progressive. Kya hai C3R? Corneal collagen cross-linking with riboflavin, C3R treatment, okay? So this way you can answer as a treatment of choice if it is in an MCQ form, but actually its role is when the keratoconus is progressive, right? Agar aapse puchta hai what is the choice of contact lens for keratoconus, definitely I think this is absolutely clear to you all. If this is the conical cornea and like this, if you're using a soft lens, what happens? The soft lens is just taking the shape of the cornea, but in a semi-soft, it replaces the whole thing with a smooth surface. So you should answer rigid gas permeable lenses. Okay. So you will answer rigid gas permeable lenses are used in keratoconus. This is the choice. This is also exam question. One question was, how do you differentiate Vogt stria and Hab stria? We know both are break in the Descemet's membrane. Vogt is vertical. This is your Vogt stria. This is feature of keratoconus. And Hab stria is mainly seen in ophthalmos, that is congenital glaucoma. Right? Both are, because Descemet's membrane is inelastic, it will break. Next slide. What do you see here? Don't forget the important topic. Please revise your vernal keratoconjunctivitis. You're looking at cobblestone appearance. What is cobblestone appearance? It is epithelial hyperplasia, which happens in spring catarrh or vernal keratoconjunctivitis. Though it is not mainly in spring, it is mainly in summers. This disease is more prominent. Which is the age group? Male children are involved. Another question, please don't forget ropey discharge. Okay, please don't forget ropey discharge. Again, a feature of vernal. What next question? Horner Tranter spots. They are again eosinophils which are seen on the limbal papilla. Okay, ये क्या होते हैं? These are eosinophils. So they ask you what type of hypersensitivity is vernal. You will answer it's a type 1 hypersensitivity reaction. Right? So you have to revise it. Come to this one. So we see this, these are flat areas, these are papilla, but this is rounded, these are follicles. So these are sago grain-like follicles of trachoma. We all know that. What are the questions in trachoma? Again, a very important topic. Please revise it properly. Okay, so what is the main important things that you have to know in trachoma? Herbert pits, Art's line, which is scarring, linear scarring on the upper lid, revise that. Then they can ask about the choice of drug of choice. You have to answer azithromycin, right? And of course, talking about your, it is one conjunctivitis which has both follicular and papillary reaction. This is also exam question, right? So revise this. We come to the next slide. You know what you're looking at. This is your Bitot spot. We are talking, please revise your xerophthalmia topic. Again, very important. So Bitot spot more common on which side? You will answer more common temporally. Of course, you should remember your WHO grading of xerophthalmia. So, next question, what is the earliest feature of xerophthalmia? You will answer earliest feature is, bolo, nyctalopia, night blindness. You should answer like this. Then they will ask you on treatment. You should know more than 1 year of the age, 1 lakh international unit, intramuscular injection given on 0, 1 and 14 days. Less than 1 year, half the dose. If you have to give oral, in each case, we double the dose. Is it simple? So more than 1 year, if the patient is more than 1 year, what are you doing? 1 lakh international unit, less than 1 year, half the dose. And if it is oral, both the cases, we double the dose. Easy now? Okay. So this is the treatment is another exam question. Then one question is, it is Bitot spot is more common temporally. One question is earliest feature, right? So hope you will remember all this. Okay. And please remember the grading also. So please revise the grading of, that is XN, X1, AB, that is conjunctival xerosis, then Bitot spot. X2, corneal xerosis. X3, keratomalacia less than 1/3 is 3A, and more than 1/3 is 3B. Then XS is scarring and XF is xerophthalmic fundus, which is white spotted fundus. याद रहेगा आपसे? There's another question, which are primary and secondary signs of xerophthalmia. That means secondary means you can see it in other features and other conditions also. So secondary signs of xerophthalmia, they ask you, it's very simple. XN, there are other causes of night blindness. XS, there are other causes of corneal scarring, and XF, other causes of white spotted fundus. Okay, so these are the secondary signs of xerophthalmia. Rest all are right. Okay, these are the questions around xerophthalmia. Of course, next slide is also very, very important. We are talking about pterygium, right? So pterygium, you all know, first question is it inflammatory or degenerative? Of course, it's a connective tissue disorder, so it's not inflammatory. Next question, more common nasally, right? It is more common nasally. Pincicula is also more common nasally. दोनों को ऐसे ही याद रखना. और क्या पूछा गया आपसे? The next question they have asked you for pterygium, which is the best method to prevent recurrence among mitomycin C and autografting? It is autografting. Just remember, autografting का एक variation है, where you are doing it, cutting a larger graft and putting a larger conjunctival, cutting a larger area as a bare sclera and then putting a larger graft. This is what is called perfect surgery. Okay, just revise it. This, I don't know, we're not very sure in Fmge they will ask you perfect surgery, but it's a very simple thing, you can know it. They can ask you anytime, right? So, and of course, another question was, how do you differentiate pseudopterygium and pterygium? Pass the glass rod underneath it. If it is not going, it is pterygium. If it is going, it is pseudopterygium. Pseudopterygium is any scar which resembles pterygium and it's just stick at the apex. Okay, right. So these are some important questions you have to keep in mind. Also remember one question, that if the pterygium is actually encroaching your pupillary area, then you have to keep this in mind, that in that case, don't wait for some time, let it cross the pupil and then remove the pterygium, because whenever you are going to remove, there's going to be some scarring. Okay, you don't want the scarring to be on the center of the pupil, right? Okay, we talk about what is this slide. This slide, if you look here, what I can see is heterochromia iridis is one observation. Affected eye is hypochromic. Can you see that? And I can see associated complicated cataract here. Can you tell me what is the condition I'm talking about? Okay, I'll give you more hints. Look here, these are stellate KPs. Now can you tell me what is this? Okay, let's see further. So there is iris atrophy. Yes, and when you are doing when you are going to do a paracentesis, there is a bleeding during gonioscopy, so this is called Amsler's sign. Yes, we are talking about Fuchs heterochromic cyclitis. So please remember and revise this from uveitis chapter. What is Fuchs heterochromic cyclitis? It is also atypical anterior uveitis, just like JRA. हमने JRA cover किया वीडियो में भी. Just go and see what is JRA. I have just recorded one video on JRA. Letter J. Okay. So similar to that, so two atypical anterior uveitis that you have to learn is one is JRA and one is fused heterochromic cyclitis. ठीक है? Okay. So in both the cases, the aim of the treatment is to manage the complications, right? Okay. We come to the next, what is the slide? You can see multiple cotton wool spots here. So we are looking at HIV microangiopathy. Exam question hai, which is the most common ocular feature of HIV? Most common feature of HIV, you will answer ocular feature is microangiopathy, and mainly what you see is cotton wool spots. Second question, most common opportunist infection. If they ask you opportunist infection, now you will answer CMV retinitis, right? Sorry. So when you say CMV retinitis, how does this present? As you can see here, this is the sauce, this is the hemorrhage, this is the cheese, which is the necrosis, isn't it? So yes, we are talking about sauce and cheese retinopathy, right? Okay, we come to the next slide. What do you see here? So if you look here, what we see here is snow banking, and we will learn this, that snow banking is pathognomic feature of intermediate uveitis or pars planitis. Okay? And of course, the next point here is, can you see this segmental sheathing which looks like candle wax drippings? So they ask you, candle wax drippings are a feature of, we all know, we are talking about sarcoidosis. Okay, so here we will talk about sarcoidosis. What is the type of uveitis? It is a granulomatous pan uveitis. This was also asked. Okay, so it's a granulomatous pan uveitis. And what are you looking here? I can see as if I'm looking through a fog, this patch of choroiditis. Yes, this is headlight in fog appearance of, where do you get this? Toxoplasmosis. Toxoplasmosis. Okay, right. And what is the last slide? So these are all uveitis slides. I think you can find the common factor here. And what is this? This is your salt and pepper fundus. Okay, seen in rubella, syphilis. So this is what is salt and pepper fundus, which is nothing but diffuse chorioretinitis, where there is a pigment dispersion which looks as if there is pepper all over. Isn't it? Salt and pepper. It's a morphological description. Right? Okay. Sorry, I sometimes feel I have to be that much fast because I have to cover. Just take some ideas. Just note down all these cues, learn and revise it, and go and read these topics more thoroughly before your exams. Okay. Yeah, we come to this one. What is this? Very, very important. What are you looking at is Dalen Fuchs nodules. Exam question. Where do you see that? Make a cue. Yes, we are talking about sympathetic ophthalmitis. Very important topic. Please revise. First, this was first question. Why? So it happens only after perforating a injury in one eye is giving uveitis in the other eye. It is due to autoimmune reaction to uveal tissue. When will this start? Only after 2 weeks. This is another question. What is the first sign and first symptom? These are the questions. First sign we will answer is retrolental flare. That means inflammation is just behind the lens in the ciliary body area. So if it is in the ciliary body area, what will be the first symptom? Ciliary muscles are responsible for accommodation. So first symptom here will be difficulty in near vision. And if this option is not given, then we can answer. So difficulty in near vision, if this is not given, then we can answer what? Tell me. Then you're going to answer photophobia. So these are some important questions on sympathetic ophthalmitis that you have to keep in mind. Please read it nicely. Okay? Yeah. And what are you looking at? This has also been your exam question. This is your Hertel's exophthalmometer. So you all know Hertel's exophthalmometer. What are we talking about here? क्या करता है? We are assessing, sorry. Hertel's exophthalmometer, we are assessing the proptosis, that is your, you know what is proptosis? That is distance from lateral orbital margin to apex of the cornea. Right? So this has been your exam question. And if you have to assess clinically, I hope you all know, please revise what is Nabziger's sign, where you are standing behind the patient, raising the chin, whichever eye is coming out first is the proptosed eye. And when you're looking from front, what is that called? That is called worm's view. Right? Another thing, let me add to the knowledge, For children, which type of exophthalmometer we use? You will answer Lude's. Okay, Lude's exophthalmometer. Right. So this was a crisp discussion. We'll follow further in the next session. We are going to complete this rapid fire discussion and revision. Okay. Hope you're enjoying. Thank you so much. Stay blessed. Keep smiling.